Hello and welcome to Triage, rapid legal lessons for busy healthcare professionals, a podcast created and produced by K&L Gates. Each episode is designed to highlight important developments in health law and analyze the impact on our clients and friends of the firm. We hope you enjoy this podcast.
Good afternoon, everyone, and welcome to today's K&L Gates Triage. My name is Jackie Hoffman, and I'm a partner in the healthcare group of K&L Gates, and I'm located in the Dallas, Texas office. I work predominantly with healthcare providers. While their businesses and the nature of the services that they provide as a provider are often different, today's environment presents similar challenges to them, and they face current reimbursement problems that are similar. With the help and input of my colleagues, I wanted to share today's discussion and presentation with you to talk about some of those issues that are familiar to and often plaguing those of us who work with providers and those of you who are providers. We all know that whether or not you have yet experienced it, COVID-19 has created and will continue to directly and indirectly create challenges, if not financial hardships, for our clients and colleagues in the reimbursement spaces. So today, I want to talk about some of the opportunities for reimbursement relief that are out there and how to think about and timely maximize those resources. Hospital finances as well have not recovered or returned to their pre-pandemic bottom lines. So in many ways, the duration of the current crisis is creating the perfect storm for providers. Hospitals are required in many instances to continue to treat the uninsured, and many of it consider part of it their mission to do so. So the question is, are there resources available to at least subsidize the care for those individuals who are uninsured or underinsured? This triage discusses those possibilities. Let's first talk about the CARES Act. The most direct form of subsidy is the Coronavirus Aid, Relief, and Economic Security Act, more familiarly known as the CARES Act. Through the CARES Act, funding is made available for uninsured COVID-19 patients. Since mid-May, providers have been able to electronically log data into a database of the Health Resources and Services Administration, or HRSA, pertaining to patients whose primary diagnosis has been COVID, in order to receive payment akin to Medicare rates. Funding, however, is only available as long as the sources last, and it's unclear due to a lack of timely and transparent accounting how much of the funding has already been used. It's also significant in that there is a limitation stating that the primary diagnosis has to be COVID, given that many patients with COVID will present with other illnesses that appear to be primary due to coding conventions. The primary diagnosis requirement continues to present risks for providers who are seeking this form of reimbursement. A primary example is pneumonia. Bilateral pneumonia often is a comorbidity with COVID. Depending on how this event is coded, the pneumonia may prevent reimbursement for COVID being the primary diagnosis. Let's talk about some other sources of provider relief. A somewhat less direct form of payment are all of the Provider Relief Fund tranches. These funds are intended to compensate providers both for increased expenses and reduced revenues associated with the pandemic. Treatment of the uninsured with COVID certainly qualifies as an expense. As to uninsureds who are not being treated for COVID, they may cause the provider's revenue to decline and can be accrued against the Provider Relief Fund award accordingly. Note that the Provider Relief Fund awards cannot be used where other funding is also being used. Therefore, by way of example, if FEMA is making payment for a case or cases, or if HRSA is paying the cost of an uninsured recipient, then the Provider Relief Fund must be earned out through some other expenses or lost revenue. There are traditional ways to address uncompensated care. Let's specifically talk about disproportionate share. As you know, more traditional ways that hospitals get compensated for uninsured patients include the Medicare and the Medicaid disproportionate share hospital payment system, commonly referred to as DSH. The Medicare DSH calculation has two components to it. One is called the uncompensated care payment and is based on data on the Medicare cost report. It has its own specific calculations and worksheet, often referred to or identified as S10. Unfortunately, it takes several years before that data tends to work its way into calculations. For instance, in the current federal fiscal year, CMS is using data from 2017 cost reports. So the cost reporting that will be demonstrative of uncompensated care directly related to COVID treatment, and specifically to the pandemic in general, which has caused other substantial costs because of delays in care by shutdowns and restricted services that are available, will not be calculated for some time. Remember also that these calculations do not result in a dollar-for-dollar recovery. Nevertheless, depending upon the length of the pandemic overhang, this additional source of funding will still be welcome years to come. Providers who are seeking to maximize their Medicare disproportionate share hospital or DSH uncompensated care payments should recognize that there is a difference between contractual write-offs, which don't qualify, and charity care, which can be furnished under a charity care policy or the hospital's financial assistance policy, or often referred to as FAP. Either way, if the provider cannot produce a policy that justifies the charity care, then it will not ultimately count towards the DSH payment. With the ongoing nature of the pandemic, no quick end in sight to the emergency declaration of the pandemic in the United States, and being on the cusp of fall and winter months that forecast rising case numbers, there is still time to review and revise these policies to maximize the likelihood of getting compensated to help offset the costs of uncompensated care. Medicaid DSH funding is also available in some cases. Medicaid DSH is subject to a cap at the amount of uncompensated care costs. That cap includes both unfunded care for uninsured or underinsured patients, as well as care for Medicaid beneficiaries. The higher the cap, the more Medicaid DSH funding an entity can receive. These amounts, as well, must not be the result of simply a write-off. Indeed, for both the Medicare and Medicaid DSH calculations, receipt of HRSA funding for a specific COVID uninsured case will result in that case being viewed as payment in full from HRSA and will not qualify for any additional payments. Because, as we discussed, availing yourself of certain sources may preclude reimbursement or compensation from elsewhere, a full financial analysis is important and necessary to decide which funding sources provide the most remunerative relief for the hospital or provider, keeping in mind that there is also a greater immediacy to items like HRSA funds as well that need to quickly be determined. Finally, let's think about other alternative sources of reimbursement that might be available to providers, sources that are both favorably and unfavorably recognized. For instance, exploring the possibility and legality of programs that assist patients with premiums, allowing individuals to obtain coverage under the ACA, may relieve reimbursement pressure on the system and providers in general, but cannot ensure reimbursement or lock in a patient to any particular provider. Remember, under this approach, a patient's care would be compensated, but it cannot ensure where, how, and from whom the patient will then choose to seek out services and care. Also, there are state funds available in certain cases through private foundations that you may want to consider. The discussion of these possibilities, while certainly worthwhile, is beyond the scope of today's triage, but can be explored by you in your state or region with further local inquiry. Thank you for joining us today. We hope that we've given you a few things to think about in considering your reimbursement challenges, and we look forward to presenting our next triage.
Thanks again for listening to Triage, rapid legal lessons for busy healthcare professionals. New episodes are available for download through iTunes, Google Play, and other podcast applications. By subscribing to Triage, you will receive timely notifications of each new episode. Also, if you have any topics that you would like to hear discussed on Triage, please don't hesitate to email triagesupport@klgates.com. We would love to hear from you.